Welcome to today's Clinical Explainer. If you spent even like one single day working on a hospital ward, you've definitely bumped into Pip-Tazo. But today, we're moving way beyond just rote memorization. We're going to transform this critical ICU topic into a practical, bedside survival guide just for you, so you know exactly how to wield it.
So, let's dive right into this everyday bedside mystery. Why do we consistently hand out a fixed 4.5 gram dose to adults without meticulously checking their milligram per kilogram weight first? I mean, we calculate weight for pediatric dosing, we do it for narrow therapeutic drugs, so why on earth not for this heavy hitter?
Well, here's our roadmap to figure that out. First, we'll tackle the ICU fixed dose mystery, then composition and core chemistry, followed by the time-dependent killing concept. After that, we'll hit clinical spectrum and indications, bedside rules and AKI, and wrap it all up with the top 3 Viva questions.
All right, kicking things off with part 1, the ICU fixed dose mystery.
The secret here is that beta-lactam antibiotics actually have this incredibly forgiving safety profile. They're designed around a standard adult weight band of, say, 50 to 90 kilograms. And because this class of drugs has such a wide therapeutic index, the risk of toxicity from a standard dose is just exceptionally low. This means we really only pause to adjust our dosing strategy for our morbidly obese patients, so folks with a BMI over 40. That's the only time we might need to step in and tweak the frequency.
Moving right along to section 2, composition and core chemistry.
Now, what's really fascinating is what actually makes up that vial. The bulk of the heavy lifting is done by 4 grams of the main beta-lactam antibiotic, piperacillin. And that massive 4,000 milligram dose is backed up by a much smaller 0.5 gram slice of tazobactam.
That breakdown perfectly illustrates the famous 8-to-1 ratio of piperacillin to tazobactam you'll find in standard adult dosing. It's not just some random mixture, you know? It's a highly precise, engineered pharmacological balance meant for maximum impact.
So why is tazobactam even in the mix? Well, the crucial thing to grasp is that tazobactam doesn't actually kill bacteria itself. Nope. It acts as a chemical shield. It's a beta-lactamase inhibitor. That means it takes the hit and protects the piperacillin from being chewed up by the defensive enzymes that resistant bacteria deploy, specifically those pesky extended-spectrum beta-lactamases, or ESBLs. Without tazobactam acting as a bodyguard, the piperacillin would be totally useless against those bugs.
Okay, let's shift gears to section 3, the time-dependent killing concept.
When it comes to actually killing bacteria, Pip-Tazo requires time above the minimum inhibitory concentration, or MIC. This is a massive pharmacological concept because it completely contrasts with concentration-dependent drugs. Take an aminoglycoside like amikacin, for example. Amikacin relies on a single, massive peak concentration in the blood. It goes for the quick knockout punch. Pip-Tazo, it sets up a long, sustained siege. So definitely remember this fundamental rule. For Pip-Tazo, you absolutely do not need a huge spike in the blood level. You just need a steady, sustained presence to effectively starve out the infection. As long as the drug concentration stays hovering above that MIC line, it's doing its job, clearing the bacteria.
And you know, this explains our administration practices perfectly. It's exactly why we use a standard 30-minute infusion for routine infections up on the general wards. But the moment we step into the ICU and face a patient in severe septic shock, we switch tactics to a 3-hour extended infusion. By dragging out that infusion time, we're maximizing that time-dependent killing, making absolutely sure the drug levels stay consistently above the MIC when a patient's life is literally on the line.
Next up, section 4, clinical spectrum and indications.
Knowing how it kills is great, but let's map out exactly what organisms this heavyweight combo actually targets. It has phenomenal gram-negative reach, capable of wiping out notorious pathogens like Pseudomonas aeruginosa, E. coli, and Klebsiella. Plus, it provides solid gram-positive cover against strep. And, this is crucial, it has fantastic anaerobic coverage against tricky bugs like Bacteroides fragilis.
However, and listen closely because this is a massive pitfall for interns, Pip-Tazo has absolutely zero activity against MRSA, literally none. If you even suspect methicillin-resistant Staphylococcus aureus in your patient, you cannot rely on this drug alone. You absolutely must add vancomycin or linezolid to your regimen. Seriously, do not miss this gap in coverage. Because of this massive broad spectrum spanning everything from Pseudomonas to anaerobes, it is your absolute go-to empirical weapon for severe hospital-acquired infections. We're talking hospital-acquired or ventilator-associated pneumonias, high-stakes febrile neutropenia, severe intra-abdominal sepsis, and dangerous aspiration pneumonias.
All right, let's transition from theory to practice with Section 5, Bedside Rules and AKI.
First things first, you've got to recognize what you're actually looking for in the medroom. You're mostly going to see this prescribed under brand names like Zosyn, Tazect, or Piperacel. Usually, you'll be grabbing the 4.5-gram vial for adults, but keep your eyes peeled for the 2.25-gram pediatric or renal vials, because you'll need those when doing dosing adjustments. Now, if you take away only one single thing from this entire explainer, please make it the renal golden rule. In the setting of septic shock with acute kidney injury, never, ever compromise that first loading dose. I don't care if the patient's kidneys have completely shut down, you do not underdose that initial hit.
The protocol here is honestly pretty straightforward. Step 1, hit them hard to save their life with the full 4.5 grams immediately. Delaying or reducing this will cost lives. Then step 2, you calculate your renal adjustments for the maintenance doses the next day, so at the 24-hour mark, based on their updated eGFR and creatinine levels.
But you've got to remember to actually make those adjustments at 24 hours. Because the drug is primarily cleared by the kidneys, letting it just build up in a patient with renal failure is incredibly dangerous. High levels of accumulated Pip-Tazo can cross right into the central nervous system, and that can lead to severe neurotoxicity and even provoke seizures. So be careful there.
Finally, let's wrap up with Section 6, Top 3 Viva Questions.
To make sure this knowledge is totally locked in, let's do a rapid-fire review of the top questions you're going to face on ward rounds. First, why add tazobactam? To act as a protective shield and inhibit ESBLs. Second, does it cover MRSA? You can confidently say no, zero activity. And third, what is its hallmark coverage? You can proudly list Pseudomonas aeruginosa and anaerobes. Boom. Easy.
I'll leave you with this clinical scenario to ponder. You've got a septic shock patient with AKI and suspected MRSA. How do you adjust their first Pip-Tazo dose, and what must you add? If you can answer that by combining the renal golden rule and the MRSA rule, you've officially mastered the bedside application of Pip-Tazo. Think it over, and I'll see you in the next explainer.